Right, let's get straight into it. This is a high-yield, exam-focused synthesis of the BASIL trial program. We're going to focus on the evidence, the crucial contrasts between the trials, and most importantly, how this work should be changing our day-to-day practice. So, the entire BASIL program, from start to finish, is really trying to answer one single massive clinical question. For our patients with chronic limb-threatening ischemia, how do we choose between surgery and endovascular treatment? And critically, how do things like anatomy and the patient's overall risk factor into that decision?
Okay, here's our game plan. We'll start with a rapid-fire review of the trials themselves. Then we'll move into a critical appraisal, really dig into the evidence, and then translate all of that into how our practice has changed before wrapping up with a final verdict.
Right, first up, let's get the core data on the table. A quick PICO review of each trial.
We'll start with the one that kicked it all off, BASIL 1.
So who were the patients? We're talking about people with severe limb ischemia from infra-inguinal disease, mostly fempop, who could have had either a bypass or an angioplasty. The intervention was a bypass-first strategy, and that was compared against a plain balloon angioplasty-first strategy. And the main things we were looking at were amputation-free survival and overall survival.
And the key message from BASIL 1? Well, in the short term, the outcomes were pretty much the same. But, and this is the crucial bit, a late benefit for bypass started to show up in those patients who had a life expectancy of more than 2 years. That time-dependent finding is absolutely key.
Okay, next up, BASIL 2.
Now the population here shifted. We're now focused specifically on patients needing an infrapopliteal revascularization. The intervention was a vein bypass-first strategy, and this was compared to a best endovascular treatment-first strategy. The primary outcome, again, was amputation-free survival.
So what was the big takeaway here? Well, the endovascular-first approach was actually linked with better amputation-free survival. And, get this, it was driven by fewer deaths, not fewer amputations. That was a really surprising and, frankly, practice-changing result.
And that brings us to the final trial, BASIL 3.
BASIL 3 switches gears. It's not about strategy anymore. It's about technology. The population was patients with CLTI, who were already chosen for an endovascular fempop procedure. The intervention was comparing drug-coated balloons or drug-eluting stents against good old-fashioned plain balloon angioplasty. Outcome was, you guessed it, amputation-free survival.
And the message from this one was crystal clear. There was no superiority of the expensive, new drug-based tech over standard plain balloon angioplasty.
Okay, so we've laid out the raw data. Now for the important part, the critical appraisal. Let's see how all these pieces actually connect.
It's so important to understand that these three trials are asking fundamentally different questions. BASIL 1 was big picture, strategy versus strategy. BASIL 2 zoomed in, strategy versus strategy, but in a very specific anatomical area, infrapopliteal disease. And then BASIL 3 zoomed in even further, device versus device within an endo strategy.
And you just cannot compare these trials without thinking about the era they happened in. BASIL 1 ran in the early 2000s. Back then, things like statins and dual antiplatelets weren't standard practice for these patients, and our endo techniques were, let's be honest, pretty basic. Fast forward to BASIL 2 and 3 over a decade later, and it's a completely different world of optimized medical therapy and much more advanced endo tech. That context changes everything.
The patient populations were also chalk and cheese. BASIL 1 enrolled patients who were generally fitter with a longer life expectancy. That's why you could even see a survival benefit for surgery emerge after 2 years. But contrast that with BASIL 2, a much sicker, frailer group of patients, with a much higher risk of dying from other things. This really helps explain why the big upfront hit of major surgery had such a negative effect in that group.
Now, methodologically, all three trials were open label, which is just pragmatic for these kinds of procedures. The intention to treat analysis keeps them valid. And importantly, the crossover you see in BASIL 1 and 2, that's not a flaw, that's just real life. It reflects how this disease progresses and that patients often need more than one procedure.
Okay, now let's properly interpret this evidence. We've got to look beyond the headlines and really understand the story that the hazard ratios are telling us.
The key concept here is something called time-dependent effects. All this means is that the impact of an intervention isn't static. It can change over time. Because of this, we have to read the hazard ratios from each BASIL trial quite differently.
So in BASIL 1, we see a story of delayed benefit. The hazard ratio for bypass actually starts off looking unfavorable, and it only crosses the line to favor surgery after 2 years. That benefit was only ever seen by the fitter patients who made it through that initial period.
BASIL 2 tells the complete opposite story, one of early harm. The hazard ratio shows an immediate, upfront disadvantage for bypass, and it stays that way. And again, this was driven by the mortality risk of major surgery in a frail population, not by a failure to save the limb.
And BASIL 3? Well, that's a story of no effect. The hazard ratios just hover right around 1.0 for the entire follow-up. This shows absolutely no statistically significant or even clinically meaningful difference between the expensive drug-eluting tech and standard angioplasty.
And that brings up a really important question. How can a trial with no significant difference, a so-called negative trial, actually be useful to us?
Because BASIL 3 gives us a really powerful practice-informing result. It gives us high-level evidence that more expensive isn't automatically better, and that gives us the confidence to stick with a more cost-effective approach as our default.
So let's put it all together. What is the final takeaway? Based on all this evidence, how has our practice actually changed?
The single most important takeaway is this. The BASIL program does not support a single, default, one-size-fits-all strategy. It definitively moves us away from a simplistic mantra like, vein is always best.
Let's break down the specific changes. 1. For femoropopliteal CLTI, bypass is still a good option for patients with a reasonable life expectancy, but it is not mandatory. 2. For infra-popliteal CLTI, an endovascular-first approach should now be our default strategy, even when there's a good vein available. And 3, when we choose endo, plain balloon angioplasty is good enough for most cases. What this all means is there's been a fundamental shift in how we should make these decisions. Factors like the patient's anatomy, their frailty, and their life expectancy are now more important than just whether or not a vein is available. It's a much more patient-centered approach.
Finally, let's put all this in the context of other major evidence and deliver our final verdict.
You know, it's important to quickly contrast BASIL with the BEST CLI trial. While BEST CLI did show a benefit for bypass in a very select group of patients with a good vein, the BASIL program, especially BASIL 2, reflects a more typical real-world cohort. You could argue its findings are much more generalizable, particularly to a publicly funded system like the NHS.
And if you remember nothing else, remember this. This is the philosophy of the entire program. Strategy matters more than technology, and patient selection matters more than the conduit.
So, my concluding judgments are these. The BASIL program is a coherent, internally consistent body of evidence that's evolved with our practice over 2 decades. And it provides the evidence we need to support an endovascular-first approach for the majority of CLTI situations we face.
Therefore, my final judgment is a clear pass for all 3 BASIL trials on their methodological quality, their pragmatic design, and their profound and lasting influence on modern vascular practice.